Hi and hello everyone. So welcome to one more MCQ discussion, and let us discuss the first MCQ. A traveler went on for a trip at high altitude mountains and developed difficulty in breathing. He was administered a diuretic considered drug of choice for this condition. What is the site of action of this diuretic on nephron? See, this is how the clinical based questions are integrated with pharmacology. So high altitude patient is going and developing difficulty in breathing due to hypoxia. So it is nothing but what we mean by acute mountain sickness. Acute mountain sickness is also called by the name high altitude sickness. So for this condition, the drug of choice and prophylactic drug, the drug of choice and the prophylactic drug is none other than acetazolamide. The drug is acetazolamide. So it's the drug of choice for acute mountain sickness, and also it is taken prophylactically before going to high altitude. Now, what is the mechanism of acetazolamide? It inhibits carbonic anhydrase. And what is the site of action in the nephron? It mainly acts on proximal converted tubule. So the answer for this question is obviously PCT, proximal convertible. So in this MCQ, we'll be learning two things. Number one, mechanisms of diuretics. Number two, drug of choice for certain conditions. Now, loop diuretics, they mainly act on loop of Henle. Loop of Henle, which part? Thick ascending loop of Henle. And what do they inhibit? They inhibit sodium, potassium, 2-chloride co-transport. Next, we have the thiazide diuretic. And where do they work? They work on early part of DCT nephron. And what do they inhibit? They inhibit sodium chloride symport. Then coming on to acetazolamide, I have already discussed. Coming on to potassium sparing diuretics. So we have number one, ENaC inhibitors. They are amiloride and triamtrin, and the mineralocorticoid receptor antagonist or aldosterone receptor antagonist, spironolactone, eplerenone. All these act on collecting duct. They act on collecting duct. So let me repeat, ENaC inhibitors are amiloride, triamtrin. Mineralocorticoid receptor antagonist are, what are those? Spironolactone, eplerenone. Now can you tell me in the comment section which part of nephron mannitol works on? Right. Now some sicknesses, I will ask you the drug of choice. Can you tell me the drug of choice for motion sickness? Motion sickness, if you are telling doxylamine, no, it is hyoscine. So we use hyoscine, right? If that is not available, we can give promethazine. Then morning sickness, which is seen in early pregnancy, that is first trimester, the drug of choice is doxylamine plus B6. And don't confuse with acute mountain sickness, the drug of choice is acetazolamide. So what did we understand from this MCQ? We understood the drug of choice for these sicknesses. Then we understood various diuretics, what is the site of action on the nephron, and what do they inhibit. And I asked you a question, what is the mechanism of mannitol and where does it work in the nephron? Right? And also remember, most of the diuretics act from the luminal side of the nephron, but the only one diuretic which acts from the interstitial side of nephron is the spironolactone, eplerenone. So coming to the question again, the answer is PCT. Next, coming to the second question, MCQ. Which of the following statement about anti-cancer drug is correct? So read and answer. Carboplatin is more neurotoxic than cisplatin. Cisplatin is nephrotoxic than carboplatin. Cisplatin causes more bone marrow suppression than carboplatin. Carboplatin causes more vomiting than cisplatin. So before we come to the answer, let us understand this. So whatever we are studying, they are called as platinum compounds. Platinum compounds, they act on the DNA, particularly binding to N7, and then they cause the damage to the DNA and cell death. So particularly important drug name is cisplatin. Cisplatin is the most emetogenic, so it induces more vomiting. That's why before giving this cisplatin, we need to give anti-emetic drugs. So what I want you to comment here is, what is the drug of choice for early CANV and late CANV? So you have to do the comments in the comment section. And also this drug cisplatin is known for neurotoxicity. So it will cause neuropathy, and also it can cause damage to the ear, ototoxicity. Patient will have ringing sensation, and it is also nephrotoxic. How do we overcome the nephrotoxicity? Number one, we can do forced chloride diuresis. So before giving this cisplatin, we can induce diuresis with sodium chloride, and then we have a cytoprotective drug. The name is called amifostin. Right, and the other adverse effect is it decreases all the ions, potassium, calcium, magnesium. So when you are using this, you have to monitor the levels of these ions. And another specialty of cisplatin is it is most widely used anti-cancer drug for most of the solid cancers. You take any solid cancer, head and neck, esophageal, stomach, testicular, ovarian, everything. It doesn't cross blood-brain barrier easily, so it's not for the brain tumors. Then what is the difference between that and this? Carboplatin and cisplatin. Now the reason why we came with carboplatin is the adverse effect what we mentioned here. These are very, very less with carboplatin. And one more thing is, will cisplatin cause bone marrow depression? Yes, but it is very minimal, that is mild to moderate. And bone marrow depression caused by carboplatin is more, and that is a dose limiting toxicity of carboplatin. So that's the difference between cisplatin and carboplatin. So based on that, the question has been framed. Now read. Carboplatin is more neurotoxic than cisplatin? No. Cisplatin is more nephrotoxic than carboplatin? Yes. All toxicity are more. Cisplatin cause more bone marrow suppression than carboplatin? No. Carboplatin cause more bone marrow suppression. Carboplatin cause more vomiting than cisplatin? No. Cisplatin is most emetogenic anti-cancer drug. Right. So what we studied from this MCQ is cisplatin is most widely used anti-cancer drug, the toxicity and how to overcome that, everything we have discussed. So I asked you a question to answer drug of choice for early CANV and late CANV. Moving on to the next question. Patient was started on anti-tubercular therapy and ART, antiretroviral therapy. Suppose patient is having HIV and tuberculosis, TB and HIV. He has to be treated for both. Now, after 2 months, symptoms worsened with fever, malaise and lymph node swelling. What can be the cause? Now, when you give anti-HIV therapy or antiretroviral therapy, the immunity is going to boost up. There is increase in immunity. The CD4 cell count will go up, and there is decrease in virus load. Now this is what happens when we give antiretroviral therapy. So when the immunity is more, it will see any bacteria or virus or anything which is latent, which is present in the body, and mount a response immediately. And that response which is mounted is called immune reconstitution inflammatory syndrome. Immune reconstitution. So remember the word here. Immune has been reconstituted. So that's why you have inflammatory response. Sometimes it can be threatened complication. So since it's an inflammatory condition, sometimes to bring down that we can use steroids. But always remember, prevention is better than cure. Suppose you get this scenario, then what to do? If patient comes to your hospital and he has both TB and HIV, what will you treat first? A patient is having TB and HIV, first to treat TB. So when you treat TB, you are reducing the bacterial load. And once you reduce the bacterial load, after 2 weeks, give a gap of 2 weeks, then you start HIV treatment. So the response, IRS, this is called immune reconstitution inflammatory syndrome, is called as IRIS. This response will be lesser if you had already killed the bacteria. So this response will be lesser if you had already killed the bacteria. So this has also been tested repeatedly. Another question they keep on asking is, suppose patient is having TB and is taking HRZD. And suppose patient is taking HIV, you have to start HIV drugs. For example, he is taking tenofovir, lamivudine and dolutegravir. Then what to do? Because rifampicin is an enzyme inducer. So what I can do? Two things. Enzyme inducer can reduce the levels of dolutegravir. So what I can do is I can increase the dose. So increasing the dose will help. Or instead of rifampicin, you can change to less enzyme inducer, that is rifabutin. So this can be done. So both the clinical cases have been asked. Let me tell you again. Suppose patient is on tubercular drugs, HRZD, and now you have to give HIV treatment. What is the option you have? Option number 1, instead of rifampicin, give the alternative rifabutin. Option number 2, increase the dose of dolutegravir. So this is the treatment aspect. So this is again important. When you treat TB and HIV, you should give a gap of 2 weeks. First treat TB, then HIV. So that is why this question is more important for you guys. Okay. Let me move on to the next question. A simple one. Which of the following is the antibiotic of choice in a child with otitis media and history of penicillin allergy? Otitis media is nothing but the infection of middle ear, usually by the bacteria or virus. And the drug of choice will be usually amoxicillin. And if it doesn't work, if there is a pus, we use clavulanic acid. Since the patient is having allergy to penicillin, they have not mentioned how much allergy, severe or whatever. So penicillin allergy, we don't use beta-lactams. We don't use beta-lactams because there is a chance of cross allergy. What do you mean by cross allergy? Suppose a person is allergic to penicillin, there is a high chance he is also allergic to other beta-lactams. What are the other beta-lactams? Cephalosporins, carbapenems, monobactams. So meropenem is a beta-lactam, I cannot give. Ceftriaxone I cannot give. Amikacin is not so much helpful in otitis media. So what is the alternative I can give is azithromycin, particularly in pediatric populations. So answer for this is A, azithromycin. Coming to the last question in this session, very important question repeatedly asked. After giving noradrenaline IV infusion, there is decrease in heart rate. The reason for decrease in heart rate is it is a integration between pharma and physio. Baroreceptor activation, stimulation of alpha-2, activation of beta-1 and inhibition of baroreceptor. So let us see that.